بسم الله الرحمن الرحيم. Anatomy is the foundation of orthopedic surgery, and the advancing knowledge of the anterior cruciate ligament anatomy has led to the development of improved modern reconstruction techniques that approach the anatomy of the native ACL. Our target is to do anatomic ACL reconstruction that mimic the normal anatomy as much as possible. The anterior cruciate ligament originates from the distal part of the medial aspects of the lateral condyle of the femur, and it's very important to remember this phrase, from the distal part of the medial aspect of the lateral condyle of the femur, and it courses anteriorly, distally as it goes, to be inserted medially into the intercondylar area of the tibial plateau, as everybody knows. So the origin is from the distal medial part of the lateral femoral condyle, and the insertion is into the intercondylar area, anterior and lateral to the medial tibial spine. Some anatomic facts: the length in average of the anterior cruciate ligament is 3.5 centimeters, and its width is around 1 centimeter. It has tendency to externalization at its fibers as it courses distally, and important to know that it has a well-marked slip of connection to the anterior horn of the lateral meniscus. See this picture, there is a slip well demarcated that connects the anterior cruciate ligament to the anterior horn of the lateral meniscus. This is a vertical MRI picture that shows rupture of the anterior cruciate ligament. And here you can note the origin of the anterior cruciate ligament from the distal. See how distal is the origin of the anterior cruciate ligament from the medial aspect of the lateral femoral condyle, and it courses anteriorly and medially to be inserted into the intercondylar area of the tibial plateau, as you can see. In extension, the anterior cruciate ligament as a whole is more or less extended. This is the AM bundle and this is the PL bundle, as we are going to see in few minutes. There is a debate around the origin of the anterior cruciate ligament as it comes out from the distal femur, regarding whether it is a separate anatomical bundles, anteromedial and posterolateral, or just functional bands of a ligament that works as one unit. However, recent anatomical investigations proved that the anterior cruciate ligament has two bundles, anteromedial bundle that arises from here and posterolateral bundle that arises from there. This is the area of the distal parts of the medial femoral of the lateral femoral condyle, the medial aspect of the lateral femoral condyle, and that's the articular cartilage all around, and that's the over the top point. So there is two bundles arising, the anteromedial that originates from over here and the posterolateral that originates from there. And if you are going to reconstruct the anterior cruciate ligament as a single bundle, you should do your femoral tunnel here between the two areas of origin of the anteromedial and the posterolateral, and I'm going to mention this in more details in over the following slides. Regarding the origin at the tibial plateau, this is the demarcation of the posterolateral, this is the demarcation of the anteromedial, and the nomenclature of the bundles comes as of the origin in the tibial plateau. I mean, when we say anteromedial bundle of the anterior cruciate ligament, it means that this bundle is anterior and medial in relation to the tibial plateau, not in relation to the femur. And the posterolateral bundle is just posterior and lateral to the anteromedial bundle, again in relation to the tibial plateau. When you see here the origin of the anterior cruciate ligament, this is the posterolateral bundle. It's shorter than the anteromedial bundle, and it is distal and anterior as it originates from the femur and goes posterior and lateral to the anteromedial bundle to attach at the tibial plateau. This is a live video to show you the normal anterior cruciate ligament. This is the AM bundle that I'm denoting, and this is the PL bundle, and there is probably a line of demarcation between both. When I probe the whole ligament, see how distal is. See how distal is the origin. See how distal is the origin of the anterior cruciate ligament as it comes out from the medial aspect of the lateral femoral condyle. This is the articular cartilage. You see, just maybe 1 centimeter or less from the beginning of the origin of the posterior lateral bundle. On the contrary, this is a completely ruptured anterior cruciate ligament. You can note here the black dot sign. Nothing here is attached to the medial aspect of the lateral femoral condyle, and there is an area that looks to be the area where the anterior cruciate ligament used to be attached there. Now some facts about the biomechanics of the anterior cruciate ligament. Everybody knows that the function of the anterior cruciate ligament controls the anterior displacement in the unloaded knee, and it resists as well rotatory instability. So it controls anterior displacement and resists rotatory instability, and there is a role as well in the varus valgus stability of the mildly flexed knee. So the mechanism of injury is going logically to be the reverse of this, the reverse of its stabilizing effect. And the most two common mechanisms of injury is twisting and stress valgus illness. Let's look at the histology of the ligament in general. The ligament structure is well to be known that it is sparsely cellular and highly collagenized. That means that the collagen bindles is abundant in the histology of a ligament, and that gives the ligament its strength and its ability to deformate at the same time. What's meant by strength? What's meant by deformation? Let's have a look on these definitions. First of all, what's laxity? Laxity is a term used to describe the looseness of the joint. How loose is this joint is its laxity. The laxity can be normal or abnormal sometimes. Right, what's deformation? Deformation is the change that occurs in the shape of a material under the effects of an applied force. How capable is this material to change its shape is the deformation. How about stiffness? Stiffness is the ability of this material to resist deformation. The ability of this material to resist the change in its shape. Right. On the other hand side, what's force? Force is the load. Force is the amount of load that causes a material to change its shape. So when there is a force, an amount of load, and the ligament is experienced to this amount of load, it deforms to some extent according to its stiffness. I mean, it will change its shape to some extent according to its resistance to change its shape, which is its stiffness. What's sprain? Sprain is incomplete rupture of a ligament when the force is too much that the deformability and the stiffness, that's the resistance to deform the shape, cannot withstand this force. Sprain will occur. What's a sprain? Incomplete rupture of a ligament. And finally, what's the strength? Strength is the capability of the ligament or a material in general to resist failure, I mean rupture. In other words, it's the degree of resistance a material shows before it fails. This is the strength. And have a look about this graph. This is the relationship between load and the deformation. As the load increases, the deformation increases. Between the points A and B is the laxity. This can be normal. When the load increases to this extent, the ligament can deform and withstand this little amount of load without any abnormalities. But whenever load increases, as load increases, the deformability or the deformation increases as well to the point C. And between B and C, is what's called by stiffness, or the resistance of the material or of the ligament in our case to resist deformation. Right. See here, this is the graph B. This is Lachman test done. Whenever you pull the tibia forward to its maximum, I mean the ligament is now deformed to its maximum. Before the load is too much high, as it occurs whenever the ligament is going to be injured in sports, for example, a sprain occurs. So the force here, the load here was increased to the extent that the ligament cannot withstand, its deformation cannot withstand. The shape has changed permanently and its stiffness did not resist enough. Sprain has occurred. What about strength of the ligament between the points C and D? That's the points between partial rupture and complete rupture, or the resistance of the ligament before it gives up. Right, regarding the bundles of the anterior cruciate ligament, there has been, as I told you, some debate whether it is separate anatomical entities, anteromedial and posterolateral, or it's just functional bands and the ligament works as one unit. Some authors, as Odenston and Gilchrist, found no anatomic separation of the ligament into different bundles. However, they did found that the ligament is twisted through 90 degrees and that both the length and the tension of different bundles, different fibers in the ligament, change as the knee flexion occurs. So there is a consensus that the bands or the bundles work in harmony while the knee is changing its position from extension to flexion, giving stability all through the way. Gergis and colleagues divided the ACL into anteromedial and posterolateral bands, and this is of course the basis behind which Fu and co-workers have also stated that the ACL is definitely divided into two different bands, anteromedial and posterolateral. Norwood and Cross further divided the ACL into three functional bundles, so it looked as if it is endless classification to 2, 3 or more. So Ames and Dawkins came to support the multifascicular structure of the ACL, which is the closest to truth. The anterior cruciate ligament is divided into a lot or uncountable fibrils and fibers that work in harmony as a multifascicular pattern, multifascicular structure, though not necessarily separate entities. Ames, who is a well-known biomechanical scientist, found and stated that the fiber bundles were not isometric, and that anteromedial bundle and posterolateral bundle shortens and lengthens as the knee changes its position from flexion to extension and the reverse, in what's called fiber recruitment concept. Fiber recruitment concept, as much needed of the fibers are recruited to tension to support the knee all through the arc of motion. Another fact that we should all know, the cruciate ligament first works as a strain gauges that measures the tension applied to the joint and the tension felt by the proprioceptive fibers based on the insertion sites of the anterior cruciate ligament are the sensors to control the limb. It stimulates the muscles by sending signals to the nervous system to control the position of the knee by these signals and to make muscles contract in harmony to give more support to the knee. So it works like sensors, and cruciate ligaments are first displacement transducers that provide input to the neuromuscular control system. Only in the extreme, they are chakrams that directly constrain motion. So the ligament works first as a sensor ligament, as a sensor organ, and next as a constraint, as a motion constraint. This is to show you the position of the knee in extension. The anterior cruciate ligament is tight. The posterolateral bundle or the posterolateral band is more tight than the anteromedial band that tightens more in the flexed position. Arthroscopic view to show you the posterolateral and anteromedial bundles all together, and this view is for the posterolateral bundle which is ruptured and the AM is intact. This is another live video to show you that the anteromedial bundle in this case is still intact while the posterolateral bundle here has been ruptured. We used to do ACL reconstruction over the past few years via the clock position. We used to do ACL reconstruction in 2 o'clock position or 10 o'clock position to guard against rotation. However, this concept now is no more in use, as whenever you change the position of the knee from extension to flexion, this concept comes out of work, as you can see here. So what are the basics that we use in ACL reconstructions recently? It's the anatomic concept. You put, especially at the knee, you put the guide pin, as you're going to see in another slide in 2 minutes. You put it in the anatomic situation, whether you do double bundle or single bundle ACL reconstruction, it doesn't matter, but you should know it in its anatomic location. 2/3 of the medial aspect of the lateral femoral condyle is out of order when you put your passing pin to do the femoral tunnel in ACL reconstruction. You should do it in the distal third. In the distal third. All the work should be done distal to the intercondylar ridge or the resident ridge, as we're going to see in a minute. This is for the PL, this is for the AM, and all together are at the distal third. So that's when we see arthroscopically in a close view, this is the lateral intercondylar ridge. Above you is the 2/3 of the medial aspect of the lateral femoral condyle of the femur, and below or distal to this lateral intercondylar ridge is the site for working in ACL reconstruction. You should do your work distal to this line, distal to the lateral intercondylar ridge, and you'll find another small ridge here that's called lateral bifurcate ridge that separates the anteromedial bundle posteriorly from the posterolateral bundle anteriorly at the distal medial femur. Another view to show you, whenever you measure first the distance of the intercondylar eminence at the tibia, it should exceed 14 millimeters to be able to do double bundle ACL reconstruction. Here is the site for the PL from the tibia, and here is the site for the AM bundle from the tibia. At the femur, this is again the lateral intercondylar ridge that your work should be distal to it, anteriorly PL, posteriorly AM. This is, as I told you, the passing pin whenever you do the femoral tunnel for ACL reconstruction. It should be distal to the lateral intercondylar ridge that is located here. As you can see, it is more or less transverse, more or less now transverse, instead of having this passing pin vertical as we used to do over the last few years. So you put it here. If you are going to do single bundle reconstruction, you put it just at the bifurcate ridge between the anteriorly located PL and the posteriorly located AM at the distal part of the medial surface of the lateral femoral tunnel. Again, to confirm this important piece of information, this is the lateral intercondylar ridge, this is the lateral bifurcate ridge at the medial aspect of the lateral femoral condyle. Anterior to the lateral bifurcate ridge is the location for tunneling of the PL, and posteriorly is the location for tunneling of the AM. This is the femoral ACL tunnel. It's been done already. This is the ACL graft test. Thank you very much.